Started with our didactic. So this talk is entitled Genotyping, One Tool in the TB Contact Investigation Toolbox. And our speaker is Katie Steinbach, who's an epidemiologist with the Minnesota Department of Health TB Control Unit. Katie has worked as a TB epidemiologist at the Minnesota Department of Health since 2017, where she monitors genotyping, provides contact investigation guidance, and learns new things about TB every day from her colleagues at home and across the country. She previously completed back-to-back master's degrees in Geographic Information Systems, or GIS, and public health at the University of Minnesota, and started her public health career in vector-borne disease surveillance. Katie, thank you very much for speaking and from joining us all the way from Minnesota. Please take it away.
Yeah, it was a really long journey from all the way over here. Give me one moment to share my slides, and then we can get started. Oh, helps when you push the share button, doesn't it? I must admit, I am more nervous for this than the in-person presentation at NTCA, so I hope, please be nice to me. Okay, and then Vita, since you're the one I can see, can you give me a thumbs up if you can see my slides?
Yes, we can see your slides.
Thank you very much. Okay, well, thank you for having me here today. I'm really excited to give this presentation. Again, if this sounds familiar to you, if you were at the contact investigation breakout session of the NTCA NAR joint conference back in April, back in Baltimore, and you attended this full session for the contact investigation, I was just a very small part of it. I hope you remember learn something new the second time around here. And if you did not attend that session or did not attend that conference, I hope that you still learned something here today, learned something new. And if you are somebody who did attend that session and you are with people who did not attend that session, no spoilers. That's no fun. And on the comment of no spoilers, we are announcing this an Olympics spoiler-free zone. So I don't want to see anything in the chat about, comments about excitement or disappointment in any Olympic activities today. Just lay the ground rules here. So I have nothing to disclose. I want to acknowledge the 74 local public health departments and 11 tribal health departments that do the work of contact investigations in Minnesota, particularly the 4 jurisdictions whose work I'm going to feature in this presentation. And then I always want to thank our friends in DTBE at CDC, the Molecular Epi and Outbreak Investigations team that support us in all the genotyping work and help us work through some weird questions that come up, and then my colleagues at the Minnesota Department of Health. I have a few references in this presentation, but mostly for those of you who are familiar with the Bible, this is the 2005 MMWR Guidelines for Investigation of Contacts of Persons with Infectious TB, and that will be providing a lot of the framework for this presentation. These are the objectives that I had to write for this. There's a different framework in a couple slides that'll make this make a little more sense. But after this presentation, what I'm hoping is that you can identify how genotyping can aid in TB contact investigations to find current cases and prevent future cases of active TB, and apply the genotyping results to investigations to support public health resource allocation decisions. So I'm going to go through some terminology and acronyms here. I am not going to explain the fundamentals of a contact investigation, and I am not going to explain the process of genotyping or interpreting the genotyping analysis that CDC does. If you have questions about either of those things, I would encourage you to reach out to your state TB program. And if you are your state TB program, particularly for the genotyping, I would recommend that you reach out to that CDC molecular epi team. They're wonderful to talk to and work with. But a few things so that we're all on the same page here. I shorten contact investigation to CI a lot. And then for the purposes of this conversation, genotype is just referring to a cluster naming convention for TB isolates that are genetically similar. And then CDC's current naming convention for genotypes that they implemented back in 2018 is this MTBC naming convention. So if you see MTBC unique, that means that you're looking at a TB isolate that is not related in any chains of transmission for culture positive cases in the United States since 2018. So not likely, that means not likely that there's a public health intervention that needs to be done to stop a chain of transmission. And if you are looking at something that says MTBC with some numbers after it, that means that that TB isolate matches, has the same cluster name as another TB isolate since 2018 in the United States. And you might need to do some public health investigation to stop a chain of transmission. So contact investigations happen in the context of your jurisdiction's TB incidents, transmission dynamics, and resources. So while this presentation has been taken out of a big contact investigation session that we did where everyone was kind of giving their context, and you could really compare and contrast and see how things are being done in different states. I want you to think about, your own population, your own jurisdiction, the own communities that you serve, and think about how you might do things similarly or differently than we're doing here based on that. So to present the context of what's going on in Minnesota, we have about 150 TB cases diagnosed per year. 17% are US born and 4% are under the age of 5. Those are kind of markers that you might have some recent transmission. We do about 72 contact investigations a year for sputum smear indicated cases, and we find about 8% of our incident cases through contact investigation. CDC publishes these nice reports of their estimates for recent cases that you can attribute to recent transmission. For Minnesota, they estimate about 8% to 12.5%, which is lower than what they estimate for the country as a whole. And we attribute 5% of our incident cases to 8 different outbreaks that we've had. To look at that a little bit differently, just looking at the genotyping. So about 2/3 of the TB isolates that we have that get genotyped, so 2/3 of our culture positive cases, the genotyping results come back and we don't need to do any kind of investigation to determine if they're part of a larger chain of transmission of culture positive cases. And then about 1/3, we might have to do some further investigation to look for epilinks and potential public health intervention. So this is the framework that I'm going to be using to go through 3 different scenarios. Oh, Jesus. So even though these guidelines were written in 2005 and genotyping has changed a lot since then, but our overall goal for contact investigation is still the same. It's to prevent future TB by finding and treating additional persons with active TB and finding and treating newly identified persons with latent TB. And out of the 13 activities that are outlined in those 2005 guidelines, I've identified 3 where we've used where genotyping has been really helpful for us in making decisions. And those areas those activities are investigating the index patient and sites of transmission, assigning priorities to contacts, and making a decision on when to expand a contact investigation. Okay, so we're going to start off with scenario 1. So this is a 2-parter here. So we start off in the fall of 2022. We are in Metro Area A in Minnesota. We have a young woman who arrived from Ethiopia in June of that year. And on paper, it looks like she could potentially be really easily transmitting TB. This is a pretty, looks kind of infectious on paper for TB. And this is a pretty typical case for Minnesota too. We have a lot of recent arrivals from Eastern Africa in our cities. For her contact investigation, 14 local household and leisure contacts are identified, and they're all family members. 1 person was previously diagnosed with latent TB. There's 6 new latent TB diagnoses made, including 2 kiddos that are US born. Everybody started and completed treatment, and there was no new active TB diagnosed. And you could look at this and you could say, Katie, you have 6 new LTBI diagnoses, and 2 of them are, this is likely their exposure for getting this LTBI, this TB infection. Why did this investigation stop here? And kind of the answer for that is, you know, what we see in our Eastern African communities, especially among recent arrivals and particularly among women, a lot of times they just got here, they're still, you know, trying to establish their new life here, and often we don't even get any context outside of their household. So this was a really kind of understandable scenario for us, and we didn't really have a reason to, you know, in conversations with the patient, to really think that they were trying to hide anything outside of their household, anything outside of their family. Like, this all made sense. So we're going to fast forward to winter and spring of 2023 in metro area B. Yes, Minnesota has more than one metro area. It's April. We get a call from a provider that there's a 3-year-old in the hospital with probable TB. So especially for all you nurses and doctors out there, when you see a 3-year-old with TB, you know that there's somebody close by who probably has TB. So when we reported this back out to the county, they're like, hey, we collected sputum at this address 2 months ago. And it turns out the person that they had collected sputum on was the 3-year-old's mom. And the very next day after we got this report, her sputum grew AFB. It was like a day 42, grew AFB, was later identified as TB. She was diagnosed with TB. In addition to being born in Ethiopia, she had also traveled to Ethiopia for several months in 2022 without the 3-year-old. Her contact investigation consisted of 17 contacts, and only 1 new LTBI diagnosis was made. And that, you know, makes sense. She was smear negative. Her TB was really slow growing, indicating like a really low bacterial load if those were good quality specimens. And now it's May, and I'm looking at this. And I am looking at the TB isolate of our metro area A case, and I'm looking at the TB isolate of our metro area B mom. And what this means is for all the DNA, that TB DNA that CDC was able to analyze, there are no differences. So we need to figure out what's going on here. So just from some Googling of like the common names of the contacts and cases, I was able to determine that these are members of the same Christian ethnic minority from present-day Ethiopia and South Sudan. And for those of you who do this work like every day, you know that a lot of times when you get these results back from CDC, that's honestly as far as you can get in making connections between these cases, is that they're from the same ethnic group. But we were able to get the jurisdictions together, and they figured out that case 1 and case 2 are related by marriage. And not only that, but case 1 first stayed in case 2's home upon arrival. So even though her destination when she was coming to the US was metro area A, she first stopped in metro area B for a few weeks. So how did genotyping help in this contact investigation? Well, it very easily answered the question of, do we need to expand this contact investigation? And that answer was yes. We knew that we had some unidentified contacts that the county needed to go back and ask the patient about, to find more people who may be at risk for TB. And then in investigating the index patient and sites of transmission. So getting these genotyping results told us we needed to get 2 jurisdictions involved without these genotyping results. This turned into a 10-case outbreak. I don't know at what point we would have put all of this together if we hadn't had genotyping. So it also prompted, with this evidence of transmission, it prompted cases to allow public health to use their name with their contacts in other cases that surfaced. And that also helped us find key proxies to learn more about exposure settings and get good contact information. And then for our overall goal of preventing future TB, 2 new active cases were diagnosed and 13 new LTBI diagnoses were made. Okay, moving on to scenario 2, university outbreak. This is going to be an excerpt of a larger outbreak that has been presented at many other meetings, I think. And so because it's like an excerpt that fits along with the theme of this talk, there's going to be some points where you're going to be like, what is wrong with you guys? Why didn't you put this together earlier? And I just want you to remember this picture. this is a pretty accurate description of what was going on at this time. So this is the TB incidents leading up to the point of the outbreak in the community. So this is a community that has a city and a university, and they get about 1 to 3 unrelated cases per year. The university does international student screening. You don't have to do that in Minnesota, but they do, which is great. And they pick up cases that way. But again, about 1 to 3 cases per year, not in the same chains of transmission. So it is May 2018, and we already know we have an outbreak. We do not need genotyping to tell us that we have an outbreak. We've already identified the presumed index case, estimated the infectious period of about 2 years. At this point, we have 3 potentially infectious cases and 587 identified contacts. We've got 6 semesters of classes. We've got 3 households. We've got 1 off-campus worksite. We've got 1 on-campus worksite. We have an additional on-campus worksite where after the site assessment, they said, you know what, this isn't a place where we are expecting transmission to have happened based on a variety of factors. And dozens of social contacts. Like the first one, there was a big word of mouth and proxy component to this contact investigation and outbreak response. So it's December 2018. We're getting our second round of genotyping back for this outbreak. I know I'm getting these results. I'm like, yep, that's the class contact. We knew that was going to be here. Social contact, sure. Household, this all makes sense. But there's another isolate on here up top. And I was like, oh boy, what happened here? So looking at our records, this is a 19-year-old international student born in Nigeria, diagnosed with extrapulmonary TB only. So what had happened was, you know, this community, as I showed, even while this outbreak was happening, there are other international students who were diagnosed with TB that were not in this chain of transmission. So because of how things were being prioritized with outbreak response, you know, she had this narrative of where she could have been exposed to TB, and because she had extrapulmonary TB only, there wasn't any kind of interview being done with her at the time of her diagnosis for contacts or potential exposure. But of course, we decided to interview her after getting these genotyping results back, and it turns out that she worked at the on-campus work site, which the original site assessment ruled out. So in this portion of this contact investigation, this helped with assigning priorities to contacts. So it helped prioritize sites where transmission was known to have occurred. All of a sudden, we had this work site that we had put at low risk or no risk. Now that was on our high priority list because we knew that something could happen there. However, for our goal of preventing future TB, about 80 folks were evaluated from this work site, and only 2 new LTBI diagnoses were made, which sounds a little fishy. So we're going to put a pin in that for now and come back to it at the end. We're going to move on to scenario 3. All right, this is our third and final scenario as promised. You guys know how this is going to go. I think you could cut up here and present this yourself, but we're going to just bring some concepts home here in this last scenario. So we're looking at a long-term care facility. So the context in which this is happening, this is our jurisdiction that has the largest incident cases of TB every year. It's about 30 to 40% of the state's incident cases. But CDC estimates that their recent transmission, their cases attributed to recent transmission is lower than what the overall state's estimates are. So there's a lot of independent, unrelated TB cases. About 8% of cases in this jurisdiction worked in healthcare in the 12 months preceding their diagnosis. Fewer than 1% were in a long-term care facility at the time of diagnosis, and we haven't had any concerns for transmission in any of these healthcare or long-term care settings in recent history in this county. So it's May of 2021, and we got a TB case that looks pretty infectious on paper. So sputum smear and culture positive. In her household contact investigation, she has a sister who was previously diagnosed with LTBI, 2 kids under the age of 5 who both have TB and LTBI ruled out. And her husband is diagnosed in July of 2021 after his sputum cultures grew TB. And also in July, a case is diagnosed in the community sputum smear positive, culture positive. Now, if you were paying attention in the last slide and you're like, Katie, you told me that 30% to 40% of your cases come from this county. Why are you telling me about a random community case? That is because case 1 worked in a long-term care setting that case 3 was in during case 1's infectious period. So the long-term care setting was known at the time of case 1's initial interview. When the county met with the long-term care facility, we have to do it. We have to put our hats back on and go back to 2021 in the winter. This was COVID times. Long-term care during COVID times. This place reports really high adherence of PPE use among staff and residents. And the reality of the situation is staff were not spending significant time with any particular patients, and people were not taking breaks in break rooms. They weren't eating in the building. When case 1 would take her lunch, her husband would come and they would eat in the car together. So they ruled out the long-term care facility as a site for potential TB transmission and decided not to do a contact investigation at that time. When case 3 surfaced and this connection was made that she had been in this long-term care facility when case 1 had been infectious, they went back to the long-term care facility, and at that time, they decided again, we don't think that this was where this transmission occurred, and we're not going to do a contact